broadcast on YouTube later. So if you don't want to be identified by your face, please switch your camera off. And also, if you are raising a question and it contains information that is personal to you, I would think twice about adding that in, because obviously it will be in the public domain there afterwards. Also to let you know that should we actually experience an intruder Zoom bombing event, we will close the meeting and just come back 5 minutes later on the connection that you came in on, which will allow us then to have restored order back to it. Okay, the meeting is now being recorded.
Pizza Boys in half an hour continue their journey to Naples, the spiritual home of pizza.
Fine. If you can remain on mute during the presentations, that would be helpful. If you don't want your entire household broadcast on YouTube. Okay, thank you. This meeting is being held bilingually, which means you are welcome to contribute in Welsh or English. For those of you who do not understand Welsh, please do the following. Scroll to the bottom of the screen. There will see an interpretation logo. Please click on that and then click on English. Good evening and a warm welcome to the online public engagement meeting. Welcome to our guest speakers. My name is Malcolm Latham, and I would firstly like to explain that I am the voluntary member and chair of the South Glamorgan Community Health Council, and I am joined by the Chief Officer, Stephen Allen. The Community Health Councils, or CHCs, are the only independent public and patient-led NHS watchdog in Wales. One of our key responsibilities is to represent the interests of the patients and public in the NHS. This evening, my role is to chair this engagement meeting and act as the honest broker in discussions. As a CHC member, I have no preconceived views or opinions as to the proposals being presented tonight. However, I am clear that my role is to ensure that the meeting is carried out in an orderly manner. This evening's engagement meeting is to discuss the proposals from the Cardiff and Vale University Health Board entitled Shaping Our Clinical Services, sometimes abbreviated to SOCS. During this meeting, if you could follow the following house rules. To help keep background noise to a minimum, please make sure you mute your microphone when you're not speaking. If you wish to ask a question during the meeting, you will need to have your video camera on and your name on the screen, unless you are using the phone or audio channel. If you choose to use a web camera, be sure it is in a stable position and focus at eye level if possible. Everyone's view is important, so please respect what they say, even if you disagree with them, because you may not know the journey that that person has made. If you want to speak while someone else is speaking, raise your hand and the chair will invite you to speak when they have finished. And you can raise that by the participants channel. There's a blue hand you can raise. You can raise a question via the chat or simply raise your hand on screen, and one of the watchers will then pick up and let me know you're waiting to come in. Inappropriate behaviour will not be permitted in this meeting. Individuals will be given 2 warnings, but if they carry on, they will be automatically removed from the meeting. Before I introduce the main speakers, I would like to draw your attention that an online response form, which was emailed to you and is also available on the CHC and Health Board websites and can be downloaded or requested, can be sent by post to you as well. Also, as public bodies, the CHC and Health Board have a duty to take into account the impact of the decisions on people with protected characteristics as laid down by the Equalities Act. To assist with this, you are invited to complete the online questionnaire, which has been emailed to you, and you can email it back to us. I'm delighted to introduce to you Dr. Nav Mansani, who is a consultant cardiologist and the Assistant Medical Director at the Health Board for this clinical strategy. Also, Vickie Lagree, who's the Programme Director shaping our clinical services, and also Abigail Harris, who is the Director of Planning. Also, Jan Janczewski, who is the chair of the Health Board, is also with us tonight, and he goes by the name of Jan to make life that much easier for you. So Jan will come in a couple of minutes' time. A record of the discussion is also being taken as people raise issues to be part of to validate what is being said and to provide some of the evidence at a later time. I intend to let the presenters finish their presentation before opening up the matter to the floor for questions and discussions. So please make a note of your question and observations during the presentation. And I now invite Jan to introduce the presentation.
Thank you, Malcolm. Noswaith pawb, croeso I gyd. Good evening, everybody, and welcome to you all. My name is Jan Janczewski. I'm the chair of Cardiff and Vale University Health Board, and I'm absolutely thrilled to be with you this evening. And thank you, Malcolm, for introducing my colleagues. That's much appreciated. This is our online engagement event, which really outlines a very exciting programme of work for us in Cardiff and Vale. And I'd like to thank the Community Health Council for agreeing to host this event and the other events taking place over the next few weeks. As a health service, we acknowledge that we do not work in isolation to improve or develop our services to make things better for our patients and staff. Rather, we need your support and contribution from our communities. At Cardiff and Vale, we're in a unique position in many ways, as we not only provide health services for our local communities across Cardiff and the Vale, but very often across the southeast region of Wales, across the whole of Wales, and in part the UK. It can be a very complicated picture to convey, and hopefully through the presentation and discussions tonight, this will help you understand the scale of the challenge facing us as a health service, why we need to change and do things differently, and as I'm sure every one of you will be aware, we are now mindful of the impact of COVID-19 on developing our health services so they are fit for the future. We are incredibly fortunate in Cardiff and Vale to have a diverse and culturally rich population, all with varying health needs at different times of our lives. Our aim is to ensure that everyone has the opportunity to lead a full and healthy life, no matter who they are or where they live. So the provision of future services is vital to ensure that we reduce health inequalities and give everyone that right. Our task is not just to think of providing health services for the future, it's also for the here and now. It's ensuring our decisions are sustainable over the long term and that they can make a real difference to our people's health and well-being. We call that improving outcomes for patients and is one of our key principles alongside caring for people and keeping them well. Please, I encourage you, make the most of this opportunity to ask questions and get involved. We really need your involvement in these very important but also exciting health discussions on the future of yours and my health service. I'm now going to hand over to Vickie Lagree to continue with the presentation. With the presentation. Diolch yn fawr. Vickie.
Thank you very much, Jan. I'm just going to share my screen and the slides here so that everybody can see. Just waiting for a nod from Malcolm and to see that they're up. Fantastic. Okay. Thank you, everybody, for being here this evening. We just wanted to take around 20 minutes or so to talk to you about the things that are happening and developing in the Health Board. So I think my colleague, Dr. Navmasani, is here, and also Abigail Harris, who's our Director of Planning. So I'm going to do a few slides just to set the scene, really, and talk about the strategy and the work we're doing at the moment, more broadly in the Health Board. Dr. Masani will pick up more specifically about the Shaping Our Clinical Services programme and what that means. And then I think Abby's going to pick up the last few slides in terms of the next steps. So we're wanting to talk to you this evening because, most importantly, the things that we've been thinking about and the changes that we've been thinking about are important to you, because they mean things for our staff and they're going to mean things for our patients in terms of where they access care and how they access care in the future. And we really want to test our thinking at this fairly early stage now about where and how these services are delivered, and really utilise the feedback that you give us to inform the next stages of our planning. So we launched our strategy in 2015. It underpins everything that we do as a health board. And that really supports us in our mission to keep people well, and our vision to ensure people have a chance of healthy life, and that's the same no matter where they live or who they are. I've just popped up on the slides there. I'll see if I can get rid of this for you. Apologies. There we go. Really the 4 key areas that are the pillars to our strategy, and we'll focus on those a little as we start to go through the presentation this evening. So Cardiff and Vale, as a health board, oversees and is responsible for a number of services. That's not only in our hospitals and our specialist hospitals, which, as Jan pointed out earlier, not only provide care for the population of Cardiff and the Vale, but we have a big role in the healthcare of our region and our nation and in Wales, and also into the UK. But we provide many services into our communities, including our community hospitals, but also our health centres, some of our health visiting and our community nursing services as well. It's most importantly, as a part of the health board, we also deliver public health, so supporting people to stay well. And that's really a key element of our strategy, and will be taken forward in a number of programmes that will be supporting our programme of work on clinical services. So 5 years on, where are we? We've done lots of work in loads of different areas, and these are just some examples for you really to have a look at, and things that we've been working on. So the development of health and wellbeing centres and wellbeing hubs in our local communities is something that's been going on for a while now, and will really support that delivery of care closer to home for patients, rather than the need for them coming into hospital. So it's important for you because it means that you no long journeys and something that's much easier access, but also making sure that we can reduce the amount of waste in our services, and that includes waiting times for you as patients. So just to highlight there, CAV 24/7, something we launched during the pandemic, but actually was something to enable patients to ring before they went into the emergency department to get a time slot so that they didn't have those long waiting times. And we touched upon the sort of regional and national role really for the health board. And in September of last year, we launched another regional specialist service that's hosted at University Hospital of Wales and the Children's Hospital in terms of the Major Trauma Centre. So we will continue to do that and build on that work. I think most importantly, over the last 12 months, the pandemic has given us huge challenges as a healthcare service, but it's also provided many opportunities to really accelerate and improve our care by delivering it in a different way. So our patients have experienced virtual clinics at home where they're able to see and speak to their consultant or their lead nurse, who might be treating them for an illness or a long-term condition. And they can do that in the comfort of their own homes, surrounded by their family and involving their family and carers if they want to. So why are we talking to you about this now? And on this slide and for the next few slides, I just wanted to highlight there's a green box on the bottom, which just guides you towards the type of questions that we're asking and we'd like you to consider while we go through the rest of the presentation. And there'll be an opportunity at the end to really go through those and remind you of them. It might spark some questions. But the health board is facing a number of challenges and has been for a number of years. As a population, and particularly in Cardiff and the Vale, we're growing. We're also ageing, and we're also becoming more isolated as we age. Our staff are seeing an increase in people with long-term illness, but also an increase of people with mental ill health. And they're seeing that and working with patients every single day. And that impacts on them also. We also recognise we've got social health inequalities, and there's a real difference within our area especially, and we need to work to reduce those inequalities and make sure that care is equal for all, no matter where you live. People are also still dying too soon from illness and disease, and these are often attributed to unhealthy lifestyle, lack of fitness, unhealthy diet, and we have a real role, I think, now to really input into that and change that right the way along our clinical services, wherever those patients are and within their sort of healthcare journey. We held a number of sessions most recently with a number of senior clinicians, and that's doctors, nurses, therapists, scientists, who all told us that developing our workforce for the future is absolutely critical, and ensuring that we can retain and recruit is really important. And we often face huge challenges with recruiting doctors and nurses and then keeping them within the profession actually. So we need to ensure that we do more to support, to educate, to look after what at the moment is a very tired workforce. But also we need to look differently at different roles and how we support our workforce to meet the challenges for the future, but also ensure that we give the best care for you, our patients. So in order to be a great place to work, we also have to have somewhere that delivers an environment that patients can receive the best care and they can recover in. And we know that the buildings that care is delivered in are a really important part of this. And anybody who's been onto our UHW site or to some of our community buildings will know that some of these are not fit for purpose anymore to meet the needs of our population. UHW in particular, University Hospital of Wales on the Heath site, was planned in the 1950s. So it's fairly outdated now when it comes to keeping up with modern medicine. And we know it's not great for our ecological footprint. So I think on that slide, I got one more slide actually before I hand over to Nav Masani, which is actually good because it's about our opportunities. So we do have lots of challenges, but we also have loads of opportunities that we really need to grab hold of. So we've got new treatments and technologies which will really support us in terms of delivering not only improved care, but also help us prevent illnesses and diseases for patients using their genetic information. We also have to take the opportunity to deliver care and make it more accessible for patients. And we can do this by really taking the opportunity to make things digital where possible for patients and deliver things closer to home. We have a big role in developing our economy, not only as an employer, but as an organisation that delivers a lot of research. And we're a real key contributor in this, and we need to develop and take the opportunity to do this for Wales as we start to recover and come out of the pandemic particularly. But also we've got a big responsibility to deliver our services for future generations and make sure that they're sustainable and make sure that they support for generations to come. On that slide, definitely on that slide now, I'm going to hand over to Dr. Masani. Nav, I will guide you through the slides, or you can guide me through the slides, but handing over to you.
Thank you, Vickie, and thanks again, Chair, for inviting us to talk. So in order to turn that strategy into a plan or a blueprint for actually how we treat patients, where we treat patients, who treats patients, we need a programme of clinical service redesign to take us into the future and deliver state-of-the-art or high-quality care allied with disease prevention and healthier lifestyles for the future. And that programme, in part, is called Shaping Our Future Clinical Services. So we're focusing mostly on clinical services for when people actually need healthcare because they have suspected or confirmed disease. We do have other programs linking into this, shaping our future well-being in the communities and shaping our future public health. And those are incredibly important pieces of work which will integrate with this clinical services piece, but that's what we're here to talk about and engage tonight. And some of the key principles within this program is that it's heavily led by clinicians, people who actually deliver healthcare, rather than politicians or managers as such. So doctors, nurses, therapists, scientists who deliver healthcare, and wrapping that around patients themselves. So designing with patients and carers, but specifically for patients and carers. And we're aware that services can appear fragmented and disconnected at times. And in the future, we would like them integrated along an entire patient journey, if you like, from home, when diseases or illnesses arise, all the way through the healthcare system, back home again to recover and refresh. So the home-to-home sort of patient journey, trying to minimize that fragmentation of care. And in order to do that, not only do we need to use the best evidence and advances in medical science, but we need to do that in partnership and integrate seamlessly with others, whether it's the public, patient groups and representatives, third sector, social care, other health boards. It needs to be integrated. That needs to be woven into the design. Next slide, please, Vickie. We've bundled together 3 large groupings at this stage, but we're pretty much open to input. One is called planned and elective care, and that's represented on this slide. And on the next slide, emergency care and highly specialized regional care. I'm just going to talk through this slide in detail. The other 2 will be relatively quick. So planned care is when you have investigations and treatments that we can arrange. We've got time, it's not an emergency, and we have the ability to look into symptoms or a medical condition in some detail. For instance, a painful hip, which might turn out to be complex, requiring an operation, or might turn out to be simple. Stomach problems, which again can range from very simple to highly complex and dangerous. And these are planned or elective care conditions. And in the past, there's been a fairly stark choice between visiting your GP and being sent to the hospital. So GP for that initial contact, and then hospital for appointments, tests, treatments, follow-up, with GP visits in between. And we think there's an opportunity to reshape this so it's much better for patients. And we've been using some of the work we've taken in COVID as a sort of forerunner of the way that things could look in the future. And that's represented on that diagram at the bottom. If you follow it through from left to right, we present in our family situation with a problem and visit the GP. But now we have new ways of blurring the lines between that primary care and specialist contact, so that GPs have new ways of consulting with us in the hospital setting, whether it's using apps or whether it's using online advice systems, or it's specialists actually visiting GP surgeries, bringing that initial contact and specialist opinion closer to the home. We have plans to expand the number of tests and assessments that we can do closer to home in community hubs, wellbeing centres and so on. And some straightforward tests, if they're linked to the hospital services, can be done much closer to home without needing to travel onto that big congested hospital site. And we can follow up patients with test results, especially if they're reassuring, with a video consultation or a telephone consultation in the home. So again, the patient gets a faster resolution to their issues, or they get told that they do need to come into the hospital, which is that next step that you see in that red circle, where we can bring patients, if it's absolutely necessary for them to come to the hospital, but deal with it much quicker and more efficiently if they don't need to come to the hospital. We have ways of getting patient feedback and monitoring conditions, again using mobile devices, which keep us closer in touch with the right patients. But we clearly will need to see patients in hospital for certain treatments and investigations. But in that follow-up cycle thereafter, that will be a blend of, again, community hub visits. So for instance, I've done cardiology clinics in North Cardiff Medical Centre, so much closer to people's homes, easier to park, or with video review and a reduced number of visits to the hospital, better for patients, better for the planet, and so on. So there are lots more ways that we can interact with our patients and their families to provide the optimal experience. That example is for planned care. If you go to the next slide, please, Vickie, we have similar models that we're developing for emergency and urgent care. Those life-threatening or life-changing conditions that we need immediate or intensive treatments or plans for, such as severe chest pain, which again might turn out to be something related to trauma like a rib fracture, or it might turn out to be something potentially life-threatening like a heart attack or head injury. There are a number of examples, and you're well aware of these. We're designing systems that direct patients to the right place with the right service, and we're blurring the lines between GP services, first contact, and specialist teams. The key here is being able to provide the right kind of response consistently throughout the 24-hour period, day and night, 7 days a week for those emergency conditions. And this is partly about meeting that challenge. And then finally, we need to develop the right pathways for those highly specialized or regional or tertiary services. And these are complex, rare, or uncommon conditions where you have to have a center of excellence and where we have a responsibility not only to Cardiff and Vale, but also to the rest of Wales. It obviously does bring benefits to Cardiff because it means we've got that expertise, highly skilled, highly tooled workforce and facilities to offer the best care locally, which is fantastic for us, but we need to make sure that it's fair and equitable across Wales. So we will be asking you in that green banner at the bottom whether or not these principles chime with you, or whether or not there are other issues that we need to consider. So next slide, please. Everyone wants to know where clinical services will actually be delivered and what services will be in which location. And as yet, we haven't finalised any plans at all. But what we do know is that the principles that we've previously consulted and engaged upon are that wherever possible, it should be as close as home as possible, in people's homes, if the technology and other things allow us for the right patients, in health and wellbeing centres, and this isn't just NHS Wales that is trying to do this, this is pretty much worldwide that we're trying to deliver the right kind of services outside of major hospital settings. And we already do this, of course, in the CRI as it's being repurposed and in other areas. And it's particularly well suited to things like mental health issues, simple diagnostic tests, children's services, and so on. We have plans to develop more sophistication in our wellbeing hubs and also integrate both health and wellbeing, so healthcare and social care in these facilities. And again, we're going to be asking those questions about how we do this, where it's felt to be of benefit. And again, it relieves pressure on the hospital services, meaning that those can concentrate on when it's really needed for the sickest patients or the highest intensity type treatments. The programme on this page is called Shaping Our Future Community Care. Next slide, please. And for shaping our future hospitals, we've been doing a piece of work for the last couple of years, trying to pull together and coordinate those services that really live together under the same set of roofs, as it were. And we know that University Hospital of Wales, which is a large teaching hospital, pulls together specialist 24/7 high intensity treatments that require a high degree of facilities, but also a world-class staff. And it allows us to also bring together a huge education facility. And it brings together those clinical services that need those facilities. So emergency medicine, such as heart attack and stroke, emergency surgery for when it's needed, intensive care units, major trauma, neurosurgery, and so on. These things have a natural grouping together. You can't really develop and deliver these things on separate sites. They clump together. And that's the way that we envisage the future University Hospital of Wales. And that has sort of compelling medical reasons, but what we need to do is make sure it's got compelling public and patient reasons as well. So our vision, you can see on the page, we want it to be environmentally friendly. We want it to be carbon neutral, sustainable both in terms of a workforce, but also an infrastructure point of view. Next slide, please. In order for that to happen, the rest of the system has to work with it as well. you can't just have a big hospital and expect it to suck in all of the sickest patients. What you need to do is an entire system of care in which patients are directed to the right element of it at every step of their pathway. And what we've learned in COVID again is that big hospitals with a mix of different patient types carry a high degree of risk. The most obvious risk is that if you are planning to go into hospital for an operation, that the last thing you want to do is be in the same place as any number of patients who are coming in with emergencies and maybe carrying, for instance, the COVID infection. That will infect staff, will infect the facility, and that person going in for a planned procedure or a planned set of treatments can be cross-infected. So you need to try and separate planned hospital admissions and those 24/7 high intensity, to some extent uncontrollable type admissions. Now, we've already done that in the Orthopaedic Centre of Excellence down at UHL, the Breast Cancer Surgery Unit down at UHL, and there's a strong case to extend that principle that our patients are already benefiting and our staff are giving us feedback on to other planned surgical or medical procedure type services. The same group of patients also require that dedicated and protected area for highly specialist rehabilitation, such as patients who've suffered a stroke and are recovering, or have got a brain or spinal injury and are being rehabilitated and retrained, for patients with long-term conditions like cystic fibrosis. And so there is a need for a protected, efficient, predictable patient pathway that takes us through a separate facility, such as UHL. And we are not decided upon exactly where every location and every service will be. This is part of our thinking and part of our consultation with our own staff and our engagement with the public. Next slide, please. Across the piece, there are three really important underpinning considerations. We've already talked about staff, but without a sustainable modern workforce that we can nurture and protect, and it is absolutely true that our NHS staff do need protection in order to provide for the public in the future, we need plans, infrastructure that is fit for purpose and nurtures and protects that NHS workforce. We also need a modern digital platform that patients can relate to, what the patients want, and isn't enforced upon those people who don't want it. So we've got to be flexible in the way that we set this up. But there are enormous patient opportunities in viewing your own tests and results, inputting into your own scheduling, taking control actually of your own healthcare to some extent, and communicating with teams in the way that we do with our families now, or indeed with these meetings. And finally, I think, you know, our Chief Exec, Len Richards, and our Director of Strategic Planning, Abby, who's on the line here, are really wedded to the fact that we need to play our part with the climate emergency. And obviously we work in the country, Wales, which is the first in embedding the well-being of future generations into its statutory obligations for public bodies. So it's, we can be proud of the country for that alone. So we're entirely wedded to that. And our question is that in addition to those issues, are there other really major issues that we need to consider as we take our next steps? And that is how I seamlessly integrate with Abby for the last slides.
Great, thank you, Vickie and Nav. So we've got 3 more slides to run through, and I'll take you through these slides. So in terms of what happens next, so this is the second of a series of meetings that we're very grateful for the CHE for hosting, but it's not the only vehicle through which we're getting feedback around the shape of clinical services that Nav and Vickie have outlined. So in addition to the public meetings that we're doing via Zoom, we are meeting with a whole range of other partners and stakeholders. So We have some existing mechanisms that we use, so things like stakeholder reference group that's got a range of partners sitting around the table, presenting to the public service boards and seeking their feedback, through third sector councils and the organisations that they reach into and represent. So a number of mechanisms. We've also clearly, hopefully you've had a chance to look at our website, but we've got lots of information on the website with the feedback questionnaires, and lots of material coming out through social media channels too. So lots of different ways in which people can share our views. So we are really keen that the questions that we've posed, that we get feedback from as many people as possible to help us make sure that the plans that we develop from this engagement are the right plans in terms of how we develop our services moving forward. What we do at the end of the engagement process is draw together what we've heard through every mechanism. So we will go through every bit of information we've had back from whichever channel, the feedback that we've had through these public meetings, and we've got people taking a record of all of the notes and the questions that are picked up, and we will collate that into a report that draws together kind of conclusions of the findings. Usually what we're able to do is group together sort of the themes that come through the feedback. So we capture all of the specific feedback and then draw that into themes. And we will be sharing that with the Community Health Council, and taking that back into our board in our May board meeting, so that the board can hear fully what we've heard during the course of the engagement process. Following reflections back into the board, we will use the learning that we've gained through the process to inform the next stages of our plans. So what you've heard today is fairly high level, and as Nav has alluded, they're at an early stage of development, so we very much welcome your input into helping us shape the next stage. And it might be that we need to undertake more detailed consultation later in the year as we put more detail onto the plans and we firm up the proposals. And again, we will take that process forward with our friends and colleagues in the Community Health Councils. So that's the process that we'll go through as we come out of the engagement process. And obviously, healthcare doesn't stay still ever, and it's changing and evolving, perhaps ever more increasingly rapidly. So the plans never remain fixed plans, because new treatments, new technologies become available to us. We have to face unforeseen things like pandemics that we hadn't anticipated and have changed our thinking about some of the way we deliver our services. And of course, we've got to respond to the sort of the recovery from COVID, as Vickie alluded to at the beginning of the presentation. Next slide, please, Vickie. I've alluded to this already. We've got plenty of points of contact for members of the public to give us their feedback, and partners and colleagues. So we really encourage and very grateful to the CHE for sharing this information too on your website, so we've got as broad a reach as we possibly can have. The final thing I'd say is that this isn't the only piece of work informing our thinking. So I've noticed that we've got one of our GP colleagues, Dr. Steve Davis, in the audience today. Nice to see you, Steve. We are doing some work around the primary care model moving forward, working with primary care colleagues. So people may be aware that Welsh Government published a sort of a national framework for primary care, a national plan for primary care. So we're working with our primary care colleagues about how to further develop primary care services, reflecting the shape of services that we've described in this presentation. We're doing some more detailed work on the health and wellbeing centres and the hubs in the community. We've got the first of our wellbeing hubs now being developed in Malva, which is fantastic news. We're feeding into this work that we're doing in other specific areas to help shape our work going forward. So Chair, that's the last slide, I believe, or there might be one. Oh, there you go. So this is just a recap on the questions that we have posed during the presentation. So it was very helpful that Nav and Vickie paused on those and drew those out. So Chair, probably without further ado, just hand back to you, and happy to open up to questions and to hear the views and comments from people who are on the call.
Okay, thank you, Abby. Firstly, I would like to thank Dr. Navansani, Vickie Lagree and Abigail Harris from the Health Board for their presentation. It is now your turn to provide comments, questions and observations, all of which will be noted for reference as part of this engagement process. Ideally, I want to afford all present an opportunity to have their say and not to cut short debate or discussion. I would like us all to adhere to the following. Firstly, could all speakers please give your name, and if you belong to an and are representing an organisation, the name of that organisation and your position within it. This is purely to assist those taking notes. Secondly, it would be appreciated if only one person would speak at a time. Again, this is to assist everyone at the meeting and to help the note taker record the questions and the answers. Thirdly, please act kindly. I am sure I don't have to ask attendees to conduct themselves with dignity and refrain from engaging in any personal attacks or acting in an aggressive manner. Finally, I would invite in questions and attempt to limit them to one per person in the first instance, in order to allow everyone the chance to contribute. It is my intention to finish no later than 9 p.m. And could we have the first question, please? Also, Vickie, I think it'd be good if we could take down the presentation. There we are. Thank you. Anybody got a question? Please either wave or send it by the chat. It's all very quiet. I can't believe everybody's not got at least one question. Okay, Ray, and then Daniel afterwards. Okay.
I think the presentation was absolutely excellent. I think it's just what the health service needed. People who don't drive, to keep it in your locality is absolutely essential. I worry slightly about older people that might not embrace modern technology. For one person who has had a hospital appointment, who have rang me, it's far easier than trying to get a bus or a taxi to get to the hospital. So I do believe, and we live quite close to CRI, so all the clinical activities that are there, I really think helps this area specifically. So I think the presentation was excellent. Couldn't ask for anything better, and thank all the people who've given the presentation. Thank you.
Thank you. Can I just remind people when they do raise a question, just to say who you are, because sometimes it doesn't show on the phone.
Right, it's Jeanette Edwards.
Thank you, Jeanette. Okay, Hilary, would you like to come in? You need to unmute first. We still can't hear you, Hilary.
I think it's Bob. Bob, we can't hear you.
Oh, sorry. Bob, can I ask you to look at the bottom of your screen? There should be a tab called translation, or can you put it onto English? Or else? No, we still can't.
I'll put a message that we can't hear.
Yeah, we can't hear you.
He's waving.
If you want to use the chat line, Bob, and write your question in.
Yeah.
Chair, I've just notified him how to do that. Okay.
Okay, lovely.
Enjoys the technology.
Anybody else want to come in while Bob is sorting out. Okay, Ray.
Yeah, you should be okay.
Right, yes, the name is Ray Edwards. I'm a member of the CHC. One of the articles I picked up, actually, it was basically medical service from home to home. Okay, I agree that yes, if somebody gets rushed in with an ambulance, there's medical service immediately to the hospital. And then once they're in the hospital and they've had the service, then they basically open the front door and you have to fend for yourself. Recently had this from a lady in my area who brought this to my attention. She was discharged from A&E 12 o'clock in the night, and she went back home to an empty house. She's in her 80s, so I just wonder if that can be checked up
Alzheimer's
on,
as well.
you know, and she does have Alzheimer's, thank you. Just wonder if that's going to be curbed or stopped in any way or corrected.
Let me go back on you.
Should we, Malcolm, do you want me to respond to that? And maybe I'll,
Yes,
I'll call Nav in. Yeah. Thank you for picking that up, Ray. I mean, clearly, our job is to make sure that every discharge from a hospital, whether it's after an attendance in A&E or after an inpatient episode, is a safe discharge. So we would hope that situation you described isn't a regular occurrence in terms of how people are supported to get back home, and to make sure that we understand what people's needs are coming out of hospital and going back home, and making sure that the support, and it might not be support that we provide, it might be support that social services or the third sector or family and friends are able to provide. But I agree, it's important to make sure that that can be provided for people. Just on a slightly broader issue, I think we've shared this before with Community Health Council colleagues and with the public around making sure that that people only come into hospital when that's absolutely necessary, and making sure that when people have had their acute hospital episode completed, that we do work with social services and other partners to ensure people can get discharged back home and have any assessment for their ongoing care needs taking place back home. And Nav, I don't know whether you want to say anything about CAV 24/7, because actually CAV 24/7 should help with making sure that we actually we can see people at a time. I mean, I know sometimes it's a blue light emergency and somebody would turn up in hospital and need to be seen very quickly at whatever time within the 24 hours is required. But actually CAV 24/7 enables us to sometimes or often book people in, even though it might be an urgent requirement, so it can be managed a little better. Do you want to say something very briefly about that?
Yes, no, I think it's a good example in the sense that it illustrates the need for us to make the changes that we're really talking about. So the first one is to try and direct patients to the right sort of service that they need 24/7. So there are more options available to that person at that moment of crisis, other than necessarily conveying them to the hospital where it's ultimately felt that they don't need to be admitted. So first of all, by increasing the number of pathways into the service, we would try and minimize the risk of that happening. And then by blurring the lines between social care, emergency services and hospital care, and of course, right in the middle of that are our community and primary and community care settings. So we have a more integrated approach. It hopefully will reduce the need for that to happen in the first place. And then once in the hospital, if we're integrating things between healthcare and other providers, such as, and it could be social care, but it could also be the voluntary sector, we will reduce the risk of that sort of thing happening again. Because ultimately, particularly if you have an old and frail person, the most dangerous place for them to be is in the hospital if they don't need to be there. So we need to design services that give ourselves a range of options here. And at the moment, the sort of traditional model is just too black and white, isn't it? So the redesign of the services along this this sort of methodology and this way of thinking really should reduce the occurrence of that sort of thing happening.
Okay, thank you, Nav. Bob, I think you may be with us now.
Can you hear me now?
We can hear you now. You're perfect now.
All right. Yeah. I've had. It's not the unmuting the microphone. It's other problems I've had with my computer. I've had this on a number of Zoom meetings that people haven't been able to hear me, and that's probably a thing that they're relieved about. But anyway, I'm glad you can hear me now. I'm Bob Woodward. I was on the CHC a large number of years ago, which Steve will remember. But I'm now just representing myself and family. I very much welcome the developments you're proposing. They're things that I think have been needed for a very long time and have been talked about for a long time, but haven't actually happened to that degree of extent. And I think there's been much too over-reliance on the Heath Hospital for all sorts of clinical services, and spreading it out to more localities is absolutely brilliant. So I very much supportive of that. I just have a couple of questions really. One general and one more specific. One is, as I was saying, we've talked about these sorts of changes for a long time, and I have to admit that my recent experience with our local GP, we have had semblance of getting much more through the GP and the delegation to GP. So we're impressed with our GP service actually, and some of these things already seem to be starting to happen. But what I'm interested in is, because what I was saying is there's been a lot of rhetoric around these things, but not much happening. So it's much more what specifics are going to change. What are you doing now that you're not going to do differently? So it's much more specific about what the changes are. And then there's the more specific thing is, you talk about a facility in North Cardiff, but where's that going to be?
Thank you for that, Bob. Nav might want to come back on some of the specifics, but just to give a kind of a general feel of the sorts of things that we've already been doing that we'd like to build on. If I can give you a couple of examples, Bob, because that might help, and one will be very specific and close to Nav's heart because he's delivering the service. One of the things that we've been doing with GP colleagues in a number of particular service areas is to look to, in a sense, work alongside primary care, our hospital doctors working alongside our primary care and GP colleagues to ensure that what might have been outpatients or patients being referred into outpatients can be seen in a different kind of way. So I would use three examples. Nav has been part of clinics for cardiology that are being delivered out in the community alongside primary care. We've done a significant amount of work in diabetes clinics being provided out into primary care, and similarly around paediatric outpatient clinics being run in a very different kind of way. That's in addition to some additional services that the Health Board has supported GPs to provide through primary care. So things like musculoskeletal conditions, we've been able to provide more provision of musculoskeletal practitioners out in primary care, supporting the full team of people, the multidisciplinary team in primary care, and similarly around mental health workers, recognizing that many of the issues that people come to their GP practice for relate to musculoskeletal or mental health issues. So those are a few examples. And the other bit is, it's not just about what we do in the Health Board. Many of you will know this very well, Bob, from in your career in government and your detailed work in relation to social care. Many of the things that people come to GP practice about might actually be things that can be better solved by other partners. So we are very keen to be developing facilities jointly where we can with local authority partners. So I mentioned very briefly Malva. We've been working over a number of years to plan the re-provision of the GP practice in the health centre and our community health facilities. And although the council was providing its hub across the road from us, we weren't really integrating the services between those two things. So Malva, we will be building on the back of the council's on the side, the council's hub in Malva, and so that there'll be a single front door, and there'll be a place for people to meet in a coffee shop. But in terms of coming through one single front door, they'll be able to access the council services, third sector services, as well as the services provided by primary care and community health services. So just a little bit of an example of the sorts of things that we're doing already, and we'd like to build on those. And then very specific, your question on North Cardiff. We don't know yet, Bob, is the answer about the best location. We've obviously still own the Whitchurch Hospital site, and we've been keeping hold of that for two reasons. One, because of the work around the Velindre Cancer Centre, but also it's quite a good location for North Cardiff. And there is a tentative proposal that we might build the Health and Wellbeing Centre for the North locality there. But we would need to test that it is the right option and the right location and has got the right kind of access. So it's by no means a fixed thing, but it's in our mind that does give us an opportunity. Nav, did you want to add anything more about the sorts of models that we've been talking about and doing already?
Yeah, I'd be very happy to. So it's a good question, Bob, because the strategy shaping our future wellbeing and the principles behind it, which we feel strongly about, has been, it was published a couple of years ago. So in terms of examples, I can talk you through some of them from home to home, if you like. So firstly, we have implemented a system called e-advice, whereby GPs who in the past would have had no real alternative other than to refer a patient to a service can use an online form to fill in patient details, and then hospital specialists reply back in a way that's held in the patient record, so securely, data protection, confidentiality, and so on, and that dialogue is recorded. For more urgent communications between GP and specialist, we've just instituted a system called Consultant Connect, which means that every specialty is signing up to having instant availability of a specialist for GP questions, and we hope that that will avoid certain admissions. So that's being rolled out at the moment. If we're looking at patients who need a planned operation, we are currently rolling out a protected surgical pathway, whereby as much as possible is done prior to the hospital admission, and that includes what we're calling a prehabilitation program, so making sure patients are supported to do the necessary exercise, give up smoking if they need to, if they can have an anaesthetic and that sort of thing, prior to coming in for their operation, are given a fixed date and what we're calling a green pathway. That means a COVID-free, protected hospital admission date, predictable length of stay, and then a supported discharge home again. So that's called a protective surgical pathway. So those things we've been implementing in the pandemic. And these are examples of the new ways of thinking that we want to design into our future hospital strategy. So there's actually quite a lot of things that are going on right now. Some of them have actually been accelerated because of the pandemic. The ones that are working, we would like to run with. The ones that aren't working, but we're having to implement by necessity, we're learning from that experience and then can improve upon. So there's a lot going on, but in amongst all of that, there are some very major programs of work that will require, for instance, big building programs. And those are as yet in the planning stage.
Thank you. I just had one specific further question, because a few months ago we had a presentation on the CHC about ophthalmic services, and that seemed to be going in a similar direction, because from personal experience, the waiting at the ophthalmic clinic hasn't been a terribly happy one. So more of those sorts of services that can get away from the heath, the better, really.
Yeah. We sorry, Vickie, you can answer that one because we're talking to the optometrists and they're in the plan. Vickie,
Absolutely. No, I was just going to say that actually, I think one thing we've recognised is that we are going to spend the next few months and have already spent the last couple of months, because we've only really sort of new into this, collecting all of those really good things that are happening, and also learning from the bad things that have happened that we don't want to do again. But certainly those good examples like ophthalmology, and there are others, audiology and different areas that we've really learned from, and giving them a sort of place and a support. And this is, I think, what this programme will look to do, is to collate those type of changes together and to support our teams on the ground to deliver more of those changes, with the extra sort of resource and support that they need to do it, so that it feels much more joined up. And because there's so many good things that are happening, and we need them to give them a place really to come together, give them that bit of vision and push them forward. So that's our job, I think, over the coming years, certainly.
Thank you.
Thank you, Bob. Any other points anybody wants to raise?
Sorry, if nobody else is raising anything, I just wanted to ask what's happening to UHW. What are the plans there for? Because you said it's past its sell-by date.
Yeah, thank you, Bob. A very good question. So I think in Nav's slides, and Vickie's slides, we alluded to the fact that the hospital, the main part of the hospital was built in the 1970s, planned for in the 1950s, and it presents many challenges to us in terms of future, current and future healthcare provision. And that has really been exposed during COVID. So, the teams of staff who've been working in the most difficult areas, particularly things like critical care, where we really don't have modern facilities. We don't. I've had the pleasure of looking around the Grange University Hospital, and these days you'd expect a critical care department to be made up of all single rooms with very good visibility between the rooms. We know that despite about 7 years ago having investment in our A&E department, the A&E department in Cardiff and Vale is one of the biggest in the UK, and the footfall through there, although we have changed some of that through the CAV 24/7, but again, it's still not a good configuration. And for some of the staff working in there, they have no access to daylight for the periods of time, long shifts that they're working. And I could go on. So we have started planning in earnest for what will be a very long process to secure capital funding and to develop the right plans to replace UHW. Our assessment is that because so much of the infrastructure and what's behind the walls and under the floors and in the ceilings is problematic, and the configuration of many of our wards is problematic, it's probably not economically viable or the best thing to try to refurbish the existing hospital, that actually it does need a replacement. And you'll probably be aware there's quite a big building program in England of replacing some of the big hospitals in England. So the process for securing funding and developing a business case is a long process and has various different stages to that. And we've just completed what we call a programme business case that we've submitted to Welsh Government. So that really is the case for change. It's setting out for ministers and decision makers why we would even want to start work on developing proposals to replace the hospital. So it doesn't talk about sites, where a future site would be, but what it signals is our clinical services are changing in the way that Nav and Vickie have described. We're developing a detailed clinical services plan, but we know that because of the changes in the way that we deliver healthcare, new treatments, new technologies, the facilities we've got at the moment are not fit for purpose. And actually, we're seeing increasing what we call business continuity challenges because of failures in our facilities. So things breaking and problems. So we've had to close theatres temporarily, those sorts of things, really challenging. So we started the process, Bob, but and it's the first stage of the 5-stage business case process. We hope to continue that and get government support to continue on to the next stage, because it's likely to be 6, 7, 8, 9, 10 years before we would complete that whole process. So we do need to start, and certainly our clinicians have had a very challenging time and continue to have challenging time without having the right kind of facilities around. So our expectation is the facility will be replaced. Obviously, what's really important to us is that we don't operate alone. Nav, I think it was in your slide, alluded to the fact that we are a big teaching centre. We teach more next generation clinicians than any other health board in Wales, and we carry out more research than anywhere else in Wales. And our partners, particularly Cardiff University, we do that jointly with them. So our plans are being taken forward jointly with the university as part of that work as well. So thank you for raising that question, Bob. It was helpful to share with people where we are with that process.
Thank you.
Thank you, Abigail. Any further questions? This will be my last call because I'll bring the meeting to an end. There's no point staring at each other for the next hour. So unless there's anything else, I'll bring the meeting to an end then. So I'll say we've now come to the end of the online engagement meeting. I wish to thank the speakers for their input and also for the clinicians who have taken part. I would especially like to thank you for attending and feeding in your comments, questions and observations into the meeting. We will ensure that the views, comments and observations you have expressed will be taken into consideration in the discussions that the CHC will have following the end of the engagement exercise in order for the CHC to respond formally to the Health Board. Could I also remind you that you have the opportunity of having your voice heard is to complete the questionnaire and return on the indicated form, or straightforwardly email into the CHC or have a conversation with the CHC. Finally, thank you all once again for attending. Can I ask Jan, as the chair of the Health Board, to say a final few words?
Thank you, Malcolm, very much. And as I said at the outset, it's a delight to be here with you today. One of the key words that my colleagues have used throughout their presentations, at Vickie, Nav and Abby, is the word shaping our services for the future. And we really want you to be involved in that shaping process. We've outlined our intention, so please contribute as full as you can and spread the word amongst your friends and families that they can contribute to. It's very, very important to us that we try and prepare services that are fit for the future, fit for our patients, and suit the needs of our patients as we go forward. One of the main drives of the health service going forward will be to try and focus very much on what the patient needs are, rather than here is a service, you have to fit in with it. We're moving away from that as far as we possibly can. So I'm ever so grateful for your contributions this evening and for taking time out of your very busy schedules to listen into our presentation. Thank you ever so much. Diolch yn fawr.
Good night, everyone.